Good afternoon. Cindy Menke here from Coretek Services. We're about to get started with this afternoon's webinar, Everything You Need to Know About Electronic Prescribing for Controlled Substances, Accommodating the Provider. Thank you for joining, and I'm looking forward to spending the next hour with you or so. So I want to take this moment to just work through some housekeeping items. First of all, everyone on the line will be muted, and but we do want to take some questions and answers for the end of the session. So if you do have anything that pops up as we're going through the information today, please use the chat mode to enter your questions, and we will answer them at the end. Also, when the session is over, we will email the deck to everyone that we'll be going through, so no need to be making fast and furious notes on anything that's up on the screen. You will get a copy of the slide deck. So with that being said, thank you very much for taking time to spend this hour with us. And let's get started. First thing is, we're still working through the next screen slide here, so bear with us. All right, so this is the first of a three-part series, Everything You Need to Know About Electronic Prescribing of Controlled Substances. Today's session, we'll be talking about the end-user experience and accommodating the provider. We're going to talk about, is it really worth it to go down this road? And then we're going to talk about the readiness for your organization to jump onto that bandwagon. In the next session, we're going to talk about, which is exactly a week from today. Bear with us again while we work through this slide deck. All right, the next session, which is exactly 1 week from today, is from the IT perspective, everything that IT needs to know about implementing electronic prescribing for controlled substances for the providers that they're supporting. First of all, we're going to talk through what the software requirements are, what the authentication considerations are, what's required for identity proofing and registration, and things like that. In the third part, which is 2 weeks from today, on June 26th at the same time, we're going to be talking about implementation best practices, specifically lessons learned, and more importantly, or most importantly, making your providers happy, because that's really what it's all about, is enabling efficient workflows for the doctors and clinicians so they can spend their time on what matters most, which is the patients. So overall, what is our goal in this series? Well, first of all, is to educate. There is so much information out there, and our purpose, or what we're endeavoring to do for you all right now, is to boil it down into something that's meaningful and actionable. So to be honest with you, e-prescribing, and especially e-prescribing for controlled substances, is really inevitable. It's coming, and we can't be burying our heads in the sand. We need to be paying attention to how the landscape is changing and what it's going to take to implement it. And it does take planning. But if you plan right, you can do it right the first time, and you can do it at a time that's right for you. So that's what we want to help you do in this series, and that's really our goal for getting together and talking about this. So let's talk about the disconnect that's feeding into this whole topic. We have two competing mandates out there. The first one comes from the federal agency of the DEA, the Drug Enforcement Agency. In March 2010, the interim final rule allowed for e-prescribing of controlled substances for Schedules 2 through 5 of controlled substances. That rule actually became effective on June 1st, 2010. And it's important to point out that it only applies to prescription center retail pharmacies. Now, why did they do this? There's pros to this. There's a reason that they did it, and they did it for their benefit, and that was to reduce potential diversion and abuse, to establish non-repudiation of who's signing for those meds, and it was, very importantly, to aid the federal government in law enforcement objectives to cut down on fraud and drug abuse. What were the cons there? Well, the cons really were that there's no consideration for the disruption in the provider workflow. Something that we take very seriously and that we spend a lot of time at Coretek is really understanding that doctor and clinician workflow to make it as streamlined and as efficient as possible to remove any technology barriers so that doctors and clinicians can honestly spend more time with their patients. Now, what else is feeding into this disconnect? What is the other mandate at work here? And that is the pharmacy, the state pharmacy boards and laws set forth by every state. Every state has its own set of laws and regulations regarding drug enforcement and drug signing and so forth. Well, the rules state that states, if they are going to enact any sort of mandate for signing of prescriptions or e-prescribing or e-prescribing for controlled substances, the DEA states that the states must be more restrictive than the DEA themselves. So that creates two competing sets of mandates that everybody has to be concerned about. So when it comes to the state mandates, New York is a great example. So they are leading the charge in this effort. And I should say kind of second in place because Ohio is actually first. We got to give a lot of kudos to Ohio because they've been doing this for a couple of years already. But for New York, and that's what we want to talk about right now, in March, their mandate is that by March 27th of 2015, all prescriptions, including prescriptions for non-controlled substances and for controlled substances, issued in the state of New York must be electronically transmitted and only with certain limited exceptions. For that entire rule, we left the website link up there. And again, like I mentioned, we will send out this deck to everybody, so don't worry about jotting that down, but we will get it to you. Now, also part of that mandate in New York is that patient prescription history must be consulted before prescribing any controlled substance by a prescription. And it's also interesting to note that New York is the only state requiring real-time reporting to track patterns of abuse by patients, doctors, and pharmacists. So one of the big abuses happening in New York was doctor shopping. In other words, going to one doctor, getting a prescription, and then wanting a refill of that prescription that you knew you weren't eligible for yet, and then going to another doctor and getting another script, and then another. So New York enacted the I-Stop law. That I-Stop law reduced doctor shopping by 74% over a 3-year time frame. So this mandate now to do electronic prescribing of controlled substances completely plays into New York's I-Stop law. So they are really setting a great example for us. Now, I understand that today we have folks on the line that are from all across the country. So for anyone on the line from New York, we'll be happy that we're talking about things that pertain to you. And for anybody not in New York where you're not mandated to do this yet, this is still great information because this will be coming. It's part of Meaningful Use Stage 3 and so forth coming up. And every state is, there's 48 states now that actually have EPCS laws in place that allow for it. So very worthwhile for anybody on the line to be hearing about today. So let's take a look at how the Affordable Care Act affects EPCS. The Center for Medicaid and Medicare Services have set forth their own mandates as well. So ARA and HITECH 2009, first thing we saw, Meaningful Use Stage 1, required 40% of all prescriptions to be sent electronically, and we're seeing great adherence to that. And for anybody who did do that, they received up to 2% in reimbursement. Then in 2012, Meaningful Use Stage 2 proposed those that e-prescribing increase up to 50%. Meaningful Use Stage 2 also allowed for the optional e-prescribing at discharge. And it was also in 2012 that we started to see penalties start occurring. Also in 2012, the reimbursement rate decreased down to 1%. Now in the middle of all this, controlled substances, the e-prescribing of controlled substances have always been exempt. So now when we talk about EPCS, that's kind of what's lending it a little bit into the confusion because there seems to be a fair amount of confusion over between what's mandated for e-prescribing compared to what's mandated for EPCS, which is the e-prescribing of controlled substances. So what happens to the provider workflow when you do adopt an e-prescribing workflow and you start to do that? Well, then when you have to prescribe a controlled substance, if you're not properly EPCS certified, now you just combine systems. You have an electronic system and a paper system, which lends to lower adoption rates overall for e-prescribing, and it opens up a big window for more errors to occur. So that brings us to what is the tipping point? What are the benefits for e-prescribing? And if you're in that 50% that hasn't gone down that road yet, what's in it for you? Let's talk about that. So first of all, there are many worthwhile benefits for e-prescribing. First off is the reduced error rate. What we see overall when you go from paper to electronic is an overall accuracy improvement of 30%. Where does that come from? On paper, we see on average 37 errors per 100 paper prescriptions, which equates to about a 63% efficiency rate. Anybody moving to electronic prescriptions, what we see there are errors reduced down to 7 errors per 100 electronic prescriptions, and that equates to a 93% efficiency rate. And do the math, it's right there. And that's an improved accuracy of 30% overall by going from paper to electronic. What are the other benefits of e-prescribing? Reduced office call volumes for refills. Also, a more complete prescription history in the medical record. Also, very important, improved medication adherence by the patients, because it's not a hassle for them to take a paper prescription to the pharmacy and then wait. By the time they get to the pharmacy, their script is ready for them. What does that equate to? Better adherence. And especially in today with meaningful use putting more and more onus on the doctor and the clinician to be responsible for the patients taking care of themselves, that's incredibly important. The other benefit are reduced prescription callbacks because of errors in a prescription. Also, we're allowed to, we see automated refill authorizations taking place, again, kind of taking away the time from the doctors and clinicians. And then also, we don't need to stock state-specific e-prescribing paper when we move off of paper. But there's more. So what are the benefits when you go to e-prescribing of controlled substances? Those exist as well. First of all, an improved provider workflow by reducing the manual forms and steps. So that's something I alluded to just a slide or two ago. If you've gone down the road of e-prescribing, but you're not certified or authorized yet to do EPCS, what you've introduced into your system then is kind of a step back in the workflow process, because now you're combining still a paper process with an electronic process. So by going down the EPCS road, you improve that entire workflow by getting rid of all of that paper and going completely electronic. The other thing it does is reduce the paper burden of maintaining those prescription records, which can be cumbersome. It also reduces our prescription forgery. And again, just like e-prescribing, we don't have to stock those state-specific e-prescribing paper, and we don't have to maintain those dedicated printers just to print prescriptions. And the same increase in accuracy of 30% is the same across the board for EPCS that we see in e-prescribing as well. So again, there are worthwhile reasons, a lot of great reasons to consider adoption. So if we've convinced you that it's worthwhile, then let's talk about, are you ready? Are you ready for EPCS? What does it take? So let's talk about the Epcs dependencies first. Things that you need to think about before you even go down that road or start planning for it. The very first one, probably most importantly, is does your state board allow for EPCS? I can tell you right now that the only 2 states where there's exceptions right now are Vermont and Kansas, and they're working on it. 48 states, though, are approved for Schedule 2 through 5 at least. Some of them also approved for Schedule 2 through 5. Best way is to check your own state government board of pharmacy for what their specifics are. The next thing to think about is your EMR application. Is it EPCS certified? So I can tell you right now, to date, The ones that are listed on the screen here: Epic, Cerner, McKesson Paragon, McKesson Horizon, Meditech, Healthland, and Siemens. Of course, that list is always growing and changing, and every one of those has some of their own nuances also about restrictions around or how their own system handles EPCS. For example, it might be an extra module that you may have to pay extra for. It will change your workflow. So there's things to be considered there as well, things that we could talk about with you later. The other thing to think about is your local pharmacy, because again, if your local pharmacy can't support EPCS, then where are your scripts going to go? So that's the other important consideration is, does your local pharmacy support EPCS? I can tell you right now that SureScripts, being the kind of the governing factor in the middle of all of this, they have the most recent up-to-date list of who is certified to accept e-prescribing of controlled substances. So the best thing I can tell you to do there is to go check the website. Again, we'll send you the list of this. I can tell you also that the pharmacy list right now is so big I couldn't put it on the screen. There were a lot of them. So when we send out the slide deck to everyone, I'll be happy to copy the latest, greatest list from SureScripts of all the pharmacies that are supported. So next question is, if you answered yes to any of those questions, then the next thing is, now let's take a look internally. And you want to start with analyzing your current provider workflow. We'll get back to that in a second. I'll talk about the other two bullets here. After you've done a thorough analysis of your provider workflow, the next thing you want to do is acquire your signing credentials, also known as identity proofing. And that is another topic that was kind of too big to handle in today's topic. So we're going to talk about that in depth in part 2 of this series, which is next Thursday. The last bullet on the screen is the next thing you have to do is implement approved authentication technologies for electronic signature. Again, another topic that's a little bit too big to cover under the scope of today's session, and we will cover that in part 2 of the series. So with that being said, let's back up then to that first bullet, analyze your current provider workflow, and let's take a deep dive into that. I've mentioned it a couple times, now I'm going to mention it again. It's all about the provider workflow. If we can't make their lives easier and streamline their processes and make this so that it's a non-event, so they don't have to think about the technology that they're using, so that they can spend more time with their patients, then we're not doing our jobs in the IT field. So again, talking about the workflow, first thing is, do you e-prescribe today? If yes, there's going to be a bit of a change in your workflow, and if you don't, there's still going to be a change in your workflow. So again, what we need to do is, honestly, what you kind of do is follow your providers around. You get a clipboard and you walk them through with their day, and you get a feel for where they go, what are the areas that they go to, which devices do they use the most, and you get a handle on how they flow through their day. And part of that workflow analysis, something that will start to come out of that is you'll begin to identify the typical high traffic areas where EPCS may be taking place. Those areas typically include the ambulatory clinics or the patient discharges from the ER. Now the thing to point out here is that as you're going through that analysis and identifying, which doctors are in at which times and which systems do they typically use and things like that, you'll start to see some patterns emerge out of that. And you'll start to realize that not every workstation or not every area needs to be ePCS enabled. And that's okay. You shouldn't come into this thinking that if you're going to do ePCS, that every machine has to be ePCS enabled. That's really not the case. So it pays to do your homework ahead of time and analyze the workflow, identify those areas. The other thing about the workflow of the providers is understanding your EMR. I know that we talked about this already, which EMRs are certified for ePCS, but a second part to that is understanding your EMR vendor and which authentication methods that they approve as well. Now, in addition to that, when it comes to those authentication methods, you may have some in place already today. A lot of hospitals do. A lot of hospitals have proximity cards in place for things like single sign-on and tap and go, really quick access. Bottom line is, if you don't have anything in place today, that's fine, because you can invest right the first time. There's not going to be any need to rip and replace anything, so no problem there. If you do have some of those modalities or authentication methods in place today, we have to take a second look at it. First of all, those typical tap and go HID proximity readers are not supported for EPCS. They do not meet the security requirements. The next thing is that out-of-band factors, including one-time passwords that may be sent through a text message, though that is not certified or authorized for EPCS either. The other thing is, if you have built-in fingerprint readers like you see on most laptops today, they are likely not compliant either. So, and again, if you have some of this in place already, you don't have to rip it out. Remember that the DEA requires 2 of 3 methods. So what do they mean by that? The 3 methods are something that you have, like your like a smart card or token, something that you know, like a password, and something that you are, which would be a biometric. The DEA requires 2 of 3 of those things to be in place and to be secure. And what do I mean by secure? FIPS 201 compliant. That means security algorithms in place allow for error rates of less than 1 in 1,000 in being able to do positive identity identification. So, backing up, or to recap, what am I saying here? If you have proximity readers already in place, if you have one-time passwords, text messages, fingerprint readers, whatever, probably fine, and no need to rip that out. When you go to EPCS and you go to the analysis of identifying the workflow, identifying which machines you want to enable for EPCS, you will likely still leave those modalities in place, but then you will likely be adding something to accommodate the DEA requirements. So you may be adding a fingerprint reader, or you may be adding a smart card device, something like that. Well, to summarize, and I cannot believe how fast we're flying through this information, there are compelling reasons to implement electronic prescribing of controlled substances. First and foremost, it provides for a streamlined provider workflow. I feel like I'm beating a dead horse when I talk about that. It's so important to make that doctor and clinician workflow completely streamlined and efficient. Second reason, overall higher adoption rate of e-prescribing in general. So again, if you're in a situation where you have gone down the road of e-prescribing, but then you have a fair amount of doctors who are doing a lot of prescribing of controlled substances, that workflow makes it difficult for them to go back and forth between the manual and the paper. So by going to e-prescribing and e-prescribing of controlled substances all at once, you will achieve a higher overall adoption rate across the board. The next thing is that you will improve your productivity and cost efficiency by not having to maintain paper and other systems. Importantly, you will improve patient safety, and you will have overall enhanced, better security over controlled substances. What does this equate to at the end of the day? Better patient care, which is the bottom line, everything that meaningful use is driving to. And like I mentioned, meaningful use is putting more and more onus on the doctors, clinicians, hospitals, providers to be in control or help patients be in better control of their care. And overall, this is allowing us to do that, providing better patient care. Next steps I can recommend for you. Attend the next 2 webinars coming up. The next 2 Thursdays in a row, same time, 2 o'clock Eastern Time. The next topic we'll be talking about what IT needs to know to implement such a system. What are the back-end infrastructure considerations? We're going to be talking about some other great tools you can use in the back end to increase your user densities and drive down costs, things like that. We'll also be talking about the specific authentication methods and that sort of thing. In 2 weeks, June 26th, 2 o'clock, we'll be talking about implementation best practices and why they are so critically important for user adoption of the systems that you're putting in place for them. What Coretek would like to offer is a free readiness assessment. Help you to spend some time with you, understand your workflows, talk about your EMRs, maybe dig into some other systems you might have. That's the value that we can bring to all of our customers all across the whole United States, is helping them down this road. And it's not a quick road either. This is if this is something you're not thinking about implementing for at least a year, it's not too soon to be thinking about it, talking about it, and starting to do a readiness assessment. And that's something we're more than happy to help you with. You can contact us at sales@coretekservices.com or at our main number, 248-684-9400. So that concludes today's session. Really happy that you joined us. I hope it was worthwhile for you. Like I mentioned, we will be sending out the slide decks and the information that I referred to. And this is when we'd like to take some Q&A. And I do think that we had one question that was about the modalities of the readers and so forth. What are the acceptable authentication methods for e-prescribing? So like I mentioned, you have to pick two of the three, something you know, something you have, something you are. The important thing about the biometrics is that they have to be FIPS 201 compliant, which is an algorithm that provides for a less than 1 in 1,000 error rate in being able to do a positive identity correlation. And as far as there are tokens that are allowed. Some of those tokens are going to be EMR specific. And of course, passwords are still allowed as one of the two of the three methods that you can use, although we're seeing more and more people go to a single sign-on. And even in a single sign-on environment, a password will still count as one of the 2 out of 3 methods for positive ID. And I believe that's it. Thank you so very much for joining us today, and we'll talk to you next week.